Welcome to the Deep Dive, the place where we take complex research and turn it into the essential knowledge you need fast.
Hello.
Today, we're wading into a crucial, high-stakes area that often flies under the radar: communication disorders in children and adolescents.
That's exactly right.
Wait,
We're unpacking material straight from Kaplan and Sadock's comprehensive textbook of psychiatry, 11th edition, guiding you through the 5 major diagnostic categories recognized by the DSM-5-TR.
okay.
And understanding these categories is, well, it's critical because these aren't just minor developmental bumps. They are persistent impairments that can really compromise a child's academic and social future.
Right, so let's frame this up for everyone listening. The DSM-5-TR identifies language disorder, then social or pragmatic communication disorder, speech sound disorder, childhood onset fluency disorder, which most people know as stuttering, and finally unspecified communication disorder, where we'll actually zoom in on voice issues today.
And, before we dive into the specific disorders, it's really essential we get the basic terms clear. Because language and speech, they sound similar, but clinically they're quite distinct.
Okay.
Language is the code. It's the system of meaning, grammar, the rules we all use to express our ideas.
While speech is the physical act, it's the incredibly rapid motor coordination, mouth, tongue, breath that turns those ideas into spoken words.
Exactly. And then there's a third piece, pragmatics, which is about using both language and speech appropriately in a social setting. Kids need to learn that too.
So our mission today is to define each of these areas, look at the why, the etiology, and walk you through some maybe surprising clinical features and the treatment paths outlined in the chapter.
Let's get started.
Okay, first up, language disorder, or LD. This means persistent difficulties in actually acquiring and using language. And it covers both sides of the coin: expression, getting ideas out, and reception, understanding what you hear.
But here's where it gets tricky clinically. Those receptive problems, they're often the hardest to spot, and they frequently get misinterpreted. Think about a child struggling with complex directions, or maybe following a dense lecture or grasping abstract ideas. It's easy to label them as inattentive, maybe even stubborn.
Right, like they're just not trying.
Precisely. But the root cause might be a genuine failure in comprehension. Making that distinction is, well, it's huge.
And that's related to why the DSM-5-TR now combines what used to be separate categories, right? The expressive and the mixed receptive expressive disorders.
Exactly. It acknowledges that these often overlap and coexist, so it's now under this single language disorder umbrella.
How common is this?
Well, the scope is wider than many people realize. Prevalence estimates, they vary wildly in the literature, anywhere from 3% maybe up to 15%, depending on who's being studied.
Wow, that's a big range.
It is. And we also see a really striking sex difference. It's much more common in boys, with ratios reported as high as 5 boys for every 1 girl.
5 to 1, okay. Is there good news in terms of prognosis?
There is some. About 50% to 80% of children who show an initial delay do catch up. But if those language problems hang on past age 4, or if the child has really significant receptive difficulties, the likelihood of it persisting into adulthood goes up quite a bit. The prognosis is poorer then.
Okay, so what actually causes this? When we look at the etiology, the why.
Yeah, the textbook is clear. It's complex. There isn't one single known cause. It's multifactorial. We see genetic links being explored, with some research pointing towards chromosomes 13, 16, and 19.
Okay.
But the environmental factors described are really jarring. LD correlates strongly with low socioeconomic status, SES, and the source material gives a stark reason why: the sheer amount of linguistic input.
You mean how much language a child hears?
Exactly. They talk about this documented word gap. Some children might hear as few as 700 utterances a day, others over 11,000.
11,000 versus 700, that's staggering.
It's a profound difference in exposure that fundamentally shapes brain development for language. And this interacts with cognitive factors too, like maybe slower cognitive processing speed or specific deficits in what's called phonologic working memory, holding sounds in mind.
The chapter gives a case study, Amy, a 5-year-old. Can you paint a picture for us? How did LD show up for her?
Sure. So Amy was asked to tell the story of Little Red Riding Hood. Her storytelling was marked by really short, incomplete sentences. She'd missed the small grammatical words, the function words.
Like articles and prepositions.
Right, so she might say, Riding Hood going to Grandma's house, see how it's telegraphic. That clearly shows an expressive deficit.
Okay.
But here's the key part. When they tested her nonverbally, using pictures or gestures, her understanding, her reception of complex directions and the story itself was actually fine. It was adequate for her age.
Ah, so that split really highlights the difference between expression and reception. She understood more than she could easily say.
Precisely. And that case illustrates why digging deeper than just sophist behavior is so important.
Another thing that jumps out is comorbidity. It seems like LD rarely travels alone.
That's a huge point. The burden of comorbidity is immense. If a child has LD, their risk for other issues skyrockets.
Yeah.
Up to 90% of school-age kids with LD also have a specific learning disorder.
Mostly reading problems.
Especially reading difficulties, yes. Dyslexia is very common. And on top of that, somewhere between 30% and 60% also struggle with co-occurring ADHD, attention deficit hyperactivity disorder.
When you think about how fundamental language is, especially for social success, it kind of naturally leads us to the next diagnosis, doesn't it?
Yeah.
Social communication disorder.
It does. Social or pragmatic communication disorder, SCD, is actually a relatively new category introduced in DSM-5.
And this one focuses purely on the social use of language.
Exactly. Persistent deficits in the social use of communication. That's pragmatics. It's about understanding how context shapes meaning and how we interact effectively using both words and nonverbal signals.
Okay, so let's maybe break down those DSM criteria a bit. There are 4 core deficit areas.
That's right. The first 2 are about adapting how you communicate. So number 1 is difficulty using communication appropriately for the social context, like knowing how to greet a stranger versus your best friend.
Different levels of formality, different topics.
Right. And number 2 is failing to shift your communication style to match that context or the listener. Think about the huge difference between how you talk on a playground versus in a quiet classroom.
Or talking to a child versus an adult.
Exactly. Vocabulary, tone, even grammar changes. Kids with SCD struggle with those shifts.
Okay, what's the third area?
The third deals more with the mechanics of conversation, following the unspoken rules. Things like taking turns appropriately, knowing how to rephrase something if the other person looks confused, or using gestures and eye contact to manage the flow.
The back and forth dance of dialogue.
You got it. And the fourth criterion, this one can be really subtle and tricky. Understanding non-literal or ambiguous language.
Ah, like idioms, sarcasm, humor.
Precisely. Or making inferences. If I imply something without stating it directly, someone with SCD might miss it entirely. They tend to be very literal interpreters.
Now, because this is so focused on social communication problems, the big question comes up. How do you tell this apart from autism spectrum disorder, ASD?
That is the critical distinction.
Yeah.
And it's actually why SCD was created as a separate diagnosis. The defining line is this. A diagnosis of SCD requires the complete absence of the B criterion for ASD.
Which is?
Which is the presence of restricted, repetitive patterns of behavior, interests, or activities. Think intense, narrow interests, inflexible routines, repetitive motor movements, or unusual sensory responses. If those are present, it's likely ASD. If it's only the social communication deficits, then SCD might be the better fit.
So this category essentially provides a home for individuals who have those social pragmatic difficulties but don't have the restricted repetitive behaviors. Maybe people who used to fall under PDD-NOS and the older DSM.
That's exactly the thinking behind its inclusion. It filled a diagnostic gap.
The textbook gives another case example. N, a 17-year-old. What did SCD look like for him?
N's case really shows the potential impact, even with high intelligence. He constantly struggled to understand jokes. He'd misinterpret people's intentions, leading to him being frequently bullied. He had immense difficulty making and keeping friends.
Despite being bright.
Yes, above average cognition. But his challenges were purely in that social pragmatic realm. He didn't show any of those restricted or repetitive behaviors associated with autism. It was just the social piece that was impaired.
And what does the research say about why this happens? What are the potential causes or underlying mechanisms?
It's still an area of active research, but the chapter mentions a few key theoretical frameworks being investigated. One is deficits in theory of mind. That's the ability to accurately guess what other people might be thinking or feeling.
Okay.
Another is called weak central coherence. This suggests difficulty integrating lots of different pieces of information, like tone of voice, facial expression, context, into one cohesive social understanding. Seeing the big picture socially.
Right, getting lost in the details, maybe.
Potentially. And the third is executive dysfunction. Problems with things like cognitive flexibility, planning, and impulse control, which are all needed for smooth, adaptive social interaction.
Okay, fascinating. Now, let's shift gears pretty significantly. We've talked language meaning and social use. Now let's talk about the physical production of sound, speech sound disorder, or SSD.
Right. And this one, interestingly, is the most common communication disorder in childhood, according to the text.
And SSD is specifically about difficulties making the sounds correctly for your age.
Exactly. Producing age-appropriate speech sounds. The errors typically fall into a few categories. Omissions like saying how for house, substitutions like wabbit for rabbit, or UO for yellow, or distortions where the sound is recognizable, but just not quite right, like a flushy yes.
Is the development pattern completely off or just slow?
Generally, it's characterized by a delayed but often typical sequence of sound development. Children naturally master sounds in a somewhat predictable order.
Like the early 8 and late 8 sounds.
Precisely. Kids usually master the early 8 consonants, like MVP, fairly young. But the late 8 sounds like RLSD. Those might not be fully consistent until age 7 or even 8 in typical development.
So with SSD, these sounds are late or maybe error patterns stick around too long?
Both can happen. Common error patterns that young children use, called phonologic processes like dropping the last consonant off a word, saying ka for cat, these usually disappear by a certain age. In SSD, they persist much longer than expected.
So as a parent or teacher, when should you start getting concerned? Is there a threshold for intelligibility?
Yes, the chapter gives a useful clinical rule of thumb. If by age 4, less than about two-thirds, less than 66% of what a child says is understandable to an unfamiliar listener, then a professional evaluation by a speech-language pathologist is definitely a good idea.
Okay, 2/3 by age 4. Got it. What about the cause here? Is it genetics again?
Like LD, there's no single cause pinpointed, but there is an interesting genetic association mentioned with the FOXP2 gene.
Ah, FOXP2 comes up a lot in language and speech research.
It does. It seems specifically related to the brain's ability to sequence the rapid, incredibly fine motor movements needed for clear speech articulation. It suggests the core issue is often in the brain's motor planning or coordination, not necessarily a physical problem with the mouth itself, although subtle brain differences are also noted.
When it comes to treatment for SSD, the text contrasts two main approaches. Can you explain those?
Sure. The first is the traditional approach. This one is very focused. It targets the physical production of single, specific sounds that are in error.
So if a child just struggles with the R sound, for example.
Exactly. If the errors are isolated to just one or two sounds, this highly focused, drill-based practice on producing that sound correctly can be very effective.
But then there's the phonologic approach. How is that different?
The phonologic approach looks at the bigger picture. It doesn't focus on individual sounds as much as it focuses on the patterns of errors.
Like that final consonant deletion example.
Right. If a child is dropping the final consonant on lots of different words, K for cat, do for dog, B for bed, the problem isn't just one sound, it's a whole rule or pattern that's missing. The phonologic approach targets that entire class of errors, often emphasizing how using those final sounds changes the meaning of words. It's often more efficient for kids with many error patterns.
Makes sense. Okay, our fourth category takes us into rhythm and flow. Childhood onset fluency disorder, commonly known as stuttering.
Yes, and this is defined by those involuntary disruptions in the forward flow of speech. We see things like repetitions of sounds or syllables, or prolongations where a sound is stretched out, snake, or silent blocks where the person just can't get the word out.
But it's often more than just the audible disruption, right? The chapter mentions secondary characteristics.
Absolutely critical point. We have to look beyond just the sounds the listener hears. The severity of stuttering is often greatly increased by these secondary or accessory characteristics. These can be physical things like visible tension, lip tremors, eye blinking, facial grimaces, sort of struggle behaviors.
And avoidance behaviors, too.
Yes, and those can be the most limiting. This is where the speaker anticipates stuttering on a certain word or sound and actively tries to avoid it. They might switch words, talk around the difficult word, circumlocution, or even just stop talking altogether. That avoidance can really shrink their world.
The chapter touches on the nosology, the classification. DSM focuses on observable behaviors, but the speaker's internal experience matters too.
It's a key debate. The DSM criteria are based on what an observer can see and hear. But for the person who stutters, their subjective distress, the fear, the anxiety, the shame is a huge part of the disorder. True severity is really a function of how much it impacts their ability and willingness to communicate.
Etiologically, the evidence seems pretty strong for a neurological basis now, moving away from older psychological theories.
Definitely. Brain imaging studies like fMRI, consistently show differences. When people who stutter speak, there tends to be overactivation in certain areas of the right hemisphere, particularly the right frontal lateral cortex.
Whereas fluent speech is typically more left lateralized.
Exactly. Fluent speakers show more efficient, lateralized activation, mainly in the left hemisphere. People who stutter seem to recruit neural resources more broadly, bilaterally, suggesting maybe a less efficient or differently organized system for speech motor control and timing.
And that neurological evidence really helps put to rest some harmful historical ideas, doesn't it? Like the diagnosogenic theory.
Oh, absolutely. That theory, proposed way back by Wendell Johnson, basically blamed parents, suggesting that stuttering was caused by parents incorrectly labeling normal childhood non-fluencies as stuttering, making the child anxious and self-conscious.
Which sounds terrible for parents.
It was. And thankfully, it's been thoroughly debunked. We now understand stuttering has strong biological roots. Genetics play a big role too. About 50% of people who stutter have a relative who also stutters, and concordance rates in identical twins are very high.
What's the typical course? Does it go away?
Onset usually peaks around age 4. The good news is that a large majority, maybe around 80%, experience spontaneous recovery, often within a couple of years of onset.
But not always.
No, and recovery becomes much rarer after puberty. For those whose stuttering persists into adolescence and adulthood, the comorbidity picture is important again. They have about a 6-fold increased likelihood of also having a social anxiety disorder or generalized anxiety disorder.
Likely fueled by years of difficult communication experiences.
Very likely. The fear of negative evaluation, the shame, the avoidance, it can definitely feed into anxiety disorders.
What about treatment for persistent stuttering?
The chapter outlines 2 traditional streams, particularly for older adolescents and adults. One is more psychologically oriented, focusing on reducing fear and avoidance, increasing self-acceptance, managing anxiety related to speaking.
And the other?
The other focuses more on modifying the speech itself, fluency shaping techniques that teach smoother ways to initiate sounds and transition between words, or stuttering modification techniques that help manage moments of stuttering more easily. Often, a combination is used.
Okay, that brings us to our final category, unspecified communication disorder. This sounds like a bit of a catch-all.
It is, to some extent. It's used when symptoms cause significant distress or impairment, but don't quite meet the full criteria for one of the specific developmental disorders we've discussed.
Wow.
Or, importantly, it can be used when a clinician needs to diagnose an issue that falls outside those main developmental categories, like an acquired disorder. And the chapter uses this heading to discuss voice disorders.
Right, so what defines a voice disorder?
A voice is considered disordered when it's quality. Maybe it's hoarse, breathy, or strained, or its loudness, or its pitch is inappropriate for the person's age, sex, or situation, and it results in functional limitations or attracts negative attention.
What's the absolute first step if someone notices a persistent voice change?
This is critical. Any persistent change in voice, especially hoarseness or vocal pain, that lasts longer than 2 weeks, must be evaluated by an otolaryngologist, an ENT doctor,
Why so crucial?
to rule out serious organic causes, things like vocal fold nodules or polyps, cysts, laryngeal cancer, or other lesions need to be identified or excluded before any voice therapy begins.
Okay, so assuming the ENT clears the person of major organic issues like cancer or paralysis, what else can cause voice problems?
Then we look at 2 broad categories. Other organic issues, maybe smaller lesions like nodules caused by overuse or neurological issues.
Yeah.
And then functional or psychogenic causes.
Functional meaning, how the voice is used.
Exactly. Often due to vocal misuse or abuse, things like chronic yelling, excessive throat clearing, speaking at an inappropriate pitch. This can lead to muscle tension dysphonia, where the muscles around the larynx are just too tight.
Well, psychogenic.
These are fascinating. Psychogenic dysphonia involves a sudden change or even complete loss of voice, but there's absolutely no physical pathology found on examination. It's almost always linked directly to significant life stress, trauma, or emotional conflict. The psychological distress manifests physically through the voice.
Wow. The chapter mentions a couple of other specific, maybe less common, but tricky voice-related issues.
Yes, 2 interesting ones. One is puberphonia. This is mostly seen in adolescent males who retain their high-pitched pre-puberty voice even after their larynx has physically matured. It's a functional issue of not adopting the new lower pitch.
And the other sounds quite serious, paradoxical vocal fold movement.
Right, idiopathic paradoxical vocal fold movement, or PVFM. This involves sudden spasms where the vocal folds close inappropriately during inhalation, making it hard to breathe in.
That sounds terrifying and easily mistaken for asthma.
Very easily. Patients often end up in the emergency room gasping for air. But because the obstruction is only at the level of the vocal folds, asthma inhalers don't help. Treatment involves specialized behavioral breathing exercises taught by a speech-language pathologist to help control the vocal folds during breathing.
It really highlights the need for interdisciplinary care.
Absolutely. Managing voice disorders, especially the complex functional or psychogenic ones, or PVFM, often requires a team. The SLP, the otolaryngologist, and sometimes referral to psychiatry or psychology is essential if underlying psychological factors are driving the problem.
Okay, so we've covered a really wide range here today, drawing from this key chapter. Language disorder, social communication disorder, speech sound disorder, stuttering, and voice disorders.
It's quite a spectrum. And I think the recurring theme, the big takeaway, is just how common these issues are. Their immense clinical significance and those really high rates of comorbidity we talked about, LD, often co-occurring with learning disorders and ADHD, stuttering linked with anxiety. Early and accurate diagnosis and intervention are just so crucial.
Yeah, what really stands out to me is how absolutely foundational communication is for, well, everything. For learning, for relationships, for work, and seeing how difficulties in any one of these areas, language, social use, speech production, fluency, even voice quality, can create these ripple effects, leading to significant lifelong challenges, academic struggles, job difficulties, social isolation.
Risk of being bullied, developing anxiety, depression. The downstream consequences are serious.
It really underscores the importance of recognizing these disorders.
And maybe a final thought to leave our listeners with, reflecting on that diagnostic complexity we discussed. The very existence of the social communication disorder category, created specifically because the definition of autism spectrum disorder changed, is a powerful reminder.
A reminder that
Even with detailed manuals like the DSM, figuring out the precise diagnostic fit for symptoms that can overlap, especially across social communication issues, autism, anxiety, learning problems, it's not always straightforward. It remains a dynamic, ongoing, and absolutely critical challenge for clinicians working with children and adolescents today.
a crucial challenge indeed. Thank you so much for walking us through that complex material.
My pleasure.
And thank you all for joining us for this deep dive.